Hello, this is Cameron Sabat from Cutting to the Case, and I'm joined here today by Dr. William N. Levine, one of the most accomplished leaders in orthopedic surgery. Dr. Levine is the Frank E. Stinchfield Professor and Chair of the Department of Orthopaedic Surgery at Columbia University, where he also serves as Chief of the Shoulder Service and Co-Director of the Center for Shoulder, Elbow, and Sports Medicine. He's Editor-in-Chief Emeritus of the Journal of the American Academy of Orthopedic Surgeons, past Director of the American Board of Orthopedic Surgery, and past President of the American Shoulder and Elbow Surgeons. He has published over 300 peer-reviewed articles, written more than 50 book chapters, edited 11 textbooks, and delivered over 400 scientific presentations worldwide. Dr. Levine's clinical expertise focuses on arthroscopic and open surgery of the shoulder, elbow, and knee, and his career has been dedicated to advancing sports medicine at the highest levels. He's served as head team physician for Columbia Athletics for over 25 years, consulted for the New York Yankees, Major League Soccer, and the National Hockey League Players Association, and currently chairs the NFL's Shoulder and Elbow Subcommittee. Beyond his professional accolades, Dr. Levine has been honored with teaching awards, leadership awards, and recognition as one of the top 25 shoulder surgeons in the United States. It's a true privilege to welcome him to the show. Thank you for joining us.
Thanks, Cameron. It's great to be here.
Absolutely. So I'll start out with questions about your career path and leadership, because I think that's a lot of what our audience wants to know. Is you've held leadership positions ranging from department chair at Columbia to editor-in-chief at JAAOS and director of ABOS. How do you think about leadership in orthopedics, and what has shaped your philosophy?
Well, I don't think you start out, at least I certainly didn't start out saying I had to be a leader to be successful. I think part of it is getting involved early in organizations, whatever they may be, starting at your residency and then in fellowship and then certainly in practice. And if you happen to be somebody who likes to solve problems, likes to make things hopefully better, doesn't like reinventing wheels, which is one of my biggest pet peeves, where I can try to make shortcuts or make easier paths, probably a better way to think of it. I think those traits allowed me or gave me some opportunities to get into leadership positions. And for me, it started simply at the residency education level, where I really thought there was opportunities to help make the Columbia Orthopedic Residency Program a better place for the residents. It had a long and storied history. I did a fellowship here, but wasn't part of the faculty here. I didn't train here. And when I came on as an early faculty member, a young faculty member in 1998, before you were born, I noticed that there were some things that happened from a hierarchy standpoint, things that happened from a legacy standpoint that were not what I would say in the best interest for resident education and morale. And so I had to figure out, how could I actually influence change in a organization that didn't recognize it needed change? And as a young guy, 33 years old and just starting practice, that wasn't anything I learned in a textbook. It wasn't anything you could teach at a course. It was kind of, learn on the job. And that was kind of my first foray into learning about leadership. And that led to my residency director promotion a couple of years later, and then on and on. So I think for me, that's where leadership kind of starts. It starts with interest and passion, wanting to make the organization better. And I think the best leaders, the ones that I've had the most respect for and the ones that I think are most respected, are those that look at the organization to which they're leading and are doing so not for personal accolades or personal aggrandizement, but because they actually want the place to be better than the place that they inherited. And when they leave, they are leaving the place in the hands of people that will hopefully elevate the organization even higher than what you were able to achieve as a leader.
Yes, yes. Really leave it better than you found it. Philosophy can take.
That's the hallmark for me of the best leaders. There are leaders who are actually threatened by bringing in people in their organization who might be better than them, who
Mhm.
might be smarter than them, who might be better leaders than them. And I think you'll again find, Cameron, that the best leaders are not only not afraid of that, but they're actively seeking those people
Mhm.
because again, you want this place, hopefully, the place you're bleeding, you want to be the best in class. And you can't do that on your own. You need to bring in people who will elevate the bar, elevate the standards, and again, make it better.
Culture. Absolutely. Yes. And really people who aren't afraid to pass the mic to someone else when time comes. Absolutely. When it comes down to people, that's really the core of any organization. What moments or mentors were most pivotal in your journey from resident to national leader in the field?
Well, Cameron, mentorship is one of my core principles that has always been something I'm extremely passionate about. And so I always love that question, and I love paying homage to those who helped pave the way for me to be here today talking with you. Um, so when I think of mentorship, it always starts with Peter Scholes, who was a pediatric orthopedic surgeon at Case Western. And Dr. Scholes was not a residency director. He didn't have a so-called leadership position in the residency education team, if you will. But it was just kind of a well-known fact that if you were a case medical student and you wanted to go into orthopedics, then you would figure out a way to get to know Dr. Scholes because he was your conduit to hopefully getting a spot in orthopedics. And it was interesting. He was very concrete about it. He was kind of like, this is a partnership, and you have to do your part in this partnership, and I do my part in this partnership. And together, we hopefully make this work. And so he was my first mentor. And honestly, my current mentality and approach to mentorship really is to pay forward and pay homage to Dr. Scholes for giving me that opportunity because I wouldn't be here were it not for him, amongst many other mentors. And so I always remind people of all ilks, it doesn't matter how high up the food chain you are, you would not be there were it not for those who come before you. And don't forget that and try to pay it forward and try to give respect to the folks that helped you along the way. I had numerous mentors in residency, of course, but the two most influential ones were John Richmond and Tom Thornhill. John Richmond was the former chair at the New England Baptist Hospital, and Tom Thornhill, the former chair at the Brigham and Women's Orthopedic Residency Training Program. And each of them, in their own way, were instrumental in helping me achieve my goals of matching and achieving fellowships in shoulder and elbow surgery and sports medicine. So I did 2 fellowships, Cameron, and then had a whole another group of mentors, Louis Biliani, Evan Flato from Columbia in the shoulder and elbow world, and T. Mormon and Leanne Curl in sports medicine at the University of Maryland. And all of those people I would call as my core mentors. And then an important point for your listeners is that one of the beauties of academic medicine is that I have so many people that I would call mentors, now friends, that had nothing to do with my training, often had nothing to do with my subspecialty choice, but were colleagues or mentors first because of organizations, American Orthopaedic Association, AOSSM, American Shoulder and Elbow Surgeons, the Academy, etc. And so you get to meet these people who have a world of experience in mentorship. And again, you're like a sponge. You want to soak in all of the things they have to share with you. And that's another very powerful way, excuse me, to gain mentorship from people outside your immediate sphere. And the more open you are to that, and the more you bring to those relationships, the more inclined people are to want to mentor you, to want to help you. And then the cool thing that happens, Cameron, is that those relationships evolve, many of them over time, from mentor-mentee to colleague to friend. And so not all of them, but many of them, that's the natural history or the pathway. So it's really cool to see how these people who you kind of had up on a pedestal at some point might become much closer to you and really become truly friends.
Absolutely. And it sounds like you had quite the national journey on the march to orthopedics through, Maryland and Case Western and New England Baptist and Brigham, and knowing all these people as well, just across these broad networks, and getting involved with these associations early has really catapulted you throughout, the world of orthopedics, just getting to know people and humanizing the field for yourself as a medical student when you're outside looking in. I think, these are all spectacular pieces of advice. Thank you for that. And, moving forward as well, Columbia specifically has been long associated with giants in shoulder sports medicine. How have you worked to build on that legacy while defining your own vision for the department?
Well, this place, the New York Orthopedic Hospital, which is the predecessor to Columbia Orthopedics, was established in 1866. So it's one of the oldest orthopedic training programs and departments in the world, and it was started by these guys who thought that this nascent field of orthopedics back then, it was basically casting. There wasn't a lot of surgery, but people who were committed to the highest quality of care for patients. And remember, orthopedics means straight child, so scoliosis and spine was very instrumental in the early days of what was being done. Lots of bracing for bent backs and patients with curvatures and so forth. And so there's only been 10 chairs of this department in the 157, 158 years now since its inception. And I was blessed to be selected the 10th chair in 2014, following my mentor, Dr. Biliani, who was the ninth. And I had a vision of what I wanted to achieve. I wanted to capitalize on the storied history of this place, but I also wanted to change and evolve and do things that maybe hadn't ever been done. And I would say I've been blessed to have been able to oversee a number of those changes. We've done some very creative things in our recruitment. We started a spine hospital that now is dubbed the Ox Spine Hospital by recruiting 3 of the world's premier spine surgeons to Columbia. Recruited a remarkable number of amazing surgeons and physicians, both in the operative and non-operative arenas. We brought in people with outside training and outside thinking. One of the hardest things in academic medicine is if you're at Georgetown, you meet faculty who were born at Georgetown, they went to school at Georgetown, they trained at Georgetown, and now they're on staff at Georgetown. Not uncommon in academic institutions. And you understand why, because you know that person, they're a known commodity, and you know how great they are. So why wouldn't you want to recruit them? And the answer is you should. But I thought it important to be in the chair at Columbia that we also have outside influences, because the reality is if a resident trains here or a fellow trains here and they only get the Columbia way to learn, I don't think that works for every clinical scenario. Let me restate that. We know it doesn't work for every clinical scenario. So it's very important for me as a surgical educator and mentor to provide our residents, our students, our fellows with multiple ways to address the same problem. And so that was a major emphasis of my faculty recruitments was, of course, I want to retain our best. Some of my best recruitments for the faculty have been our former residents. But I also have recruited some amazing surgeons and non-operative physicians from outside the Columbia sphere, and they have added to the breadth and depth of this culture and of the family, and for the learning experience for all of the members of this department. So I think that's a really important part. And with respect to shoulder surgery specifically, Dr. Neer is the patriarch of shoulder surgery. He started the shoulder service at Columbia, which was the first of its kind. He started the first fellowship in shoulder surgery in 1977. His first fellow was Dr. Biliani, who succeeded him as the second chief of the shoulder service. And I have the incredible honor and daunting privilege to be the third chief of the shoulder service. So that can be really intimidating. And when I was a young guy here, to follow in those giants' footsteps could be overwhelming, and it could really be almost make you catatonic. Like, I can't really do this. Talk about imposter syndrome. That's the first class in imposter syndrome. So I learned early on that, and this is advice that I now obviously share with everybody in my sphere, is that you can't worry about the predecessors. It's wonderful to know the history. You should know the history. You owe it to the institution to which you're working to appreciate the history. But above and beyond that, you need to make your own history. You need to make your own path. You need to be able to be comfortable in your own skin and say, look, I'm not Dr. Neer and I'm not Dr. Biliani. I'm Bill Levine. I'm from Fargo, North Dakota originally. And I do things the way that I do them, the way I think is best. But I'm my own person. And that has served me well in the organizations to which I have been asked to serve and be a part of, because I come at it from a place that feels genuine to me, not necessarily I'm doing it just because that's the way we've always done it. And I think the more innovative you are, but the more true and genuine you are to yourself, the more success you're going to have, because you're obviously invested in it because it's something you believe strongly in.
Yes, yes, absolutely. You can't worry about the predecessors and really just focus on what you think is best for, your organization at that time. And really, you're too humble saying that. You, you had imposter syndrome, and we're thinking about previous generation. You are Dr. Levine, so no, I really appreciate you sharing that. And building on that legacy that you're growing right now at Columbia, you've now published more than 300 papers and edited 11 textbooks. What do you consider your most meaningful academic or clinical contribution so far?
Well, it's a good question, and I think that there's some articles and topics of things that we've done that I think are really impactful. Uh, One of them is an article that I had an idea for when Mike Kim was our fellow. Mike came to us from St. Louis and Kansas City and Baltimore, and originally from Korea, and was looking to do an alternative pathway to medical degree in the U.S., and that's very hard for international trainees. But so we were his third fellowship, and that's one pathway. You can do 3 clinical fellowships. And one of the things that happens with rotator cuff repairs and rotator cuff disease is this notion that, well, if it fails, the patient doesn't have a problem. Or if they have a rotator cuff tear, they don't have a problem. They can live with it. And it just seemed to me to not be accurate. In taking care of enough patients, I said, I don't believe that. That just doesn't make sense to me. And so I said, oh, here's a simple question, man, that no one had really looked at. Let's look at patient satisfaction based on the age of the patients. And so we had 3 different categories of patients, 3 different cohorts. And sure enough, we found that the age made a huge difference. And what you say at 75 is very different than what you say at age 55. And that article was published in the Journal of Bone and Joint Surgery, kind of the premier orthopedic journal. And it was all done within Mike Kim's fellowship year. He applied for the Rockwood grant from ASES, which is a $75,000 grant. We did the study, which involved Mike and one of our residents, Leslie Fink, traveling all over the tri-state area with a portable ultrasound machine and finding patients. I mean, they were unbelievable. I had the idea, but these guys were rock stars. And within his fellowship year, Mike not only completed the project, but actually got the article published by the spring of his fellowship year. It was kind of unprecedented. And I bring that story up, Cameron, because there's way too much emphasis today on quantity of research. How many papers have you published? You know very well, considering now going into orthopedic surgery as a medical student, people will on these chat rooms and the blogs will say, you have to have 15, you have to have 20, you have to have some magic number. And I couldn't disagree more. And a lot of that, like to me, publishing 20 articles in what I like to fondly refer to as the Journal of Irreproducible Results is of absolutely no value to anybody. It's not of value to patients. It's not of value to society. And the only thing it's of value to marginally, perhaps, is to your CV so that you look like you've been a very productive person. So I think all too often we kind of get trapped with that. I get it. That's the world we live in. So for me, when I've been able to ask a clinical question and then either go to the laboratory and examine that question and study that question, or a clinical question and then do a clinical study that actually changes patient care or impacts patient care, now we're talking. Now we're talking about something that's impactful and meaningful. And so that's for me how my research endeavors and interests over the years have always been based on clinical questions. So my involvement with biomedical engineering with Helen Liu at Columbia, for example, we've developed a nanofiber scaffold to help improve rotator cuff repair healing. Well, that's a really critical problem that doesn't have a solution. Getting involved with Zimmer Biomet as a surgeon designer and designing an entire shoulder arthroplasty system with 9 of my dear friends from around the world and the country, and seeing that come to fruition. And I had to put the first one in a live patient in 2022. You talk about being nervous, Cameron. Like I put in thousands of shoulder replacements, but I haven't put any that have my name on it. I haven't put any that I'm a surgeon designer for. And that was very frightening because God forbid our wonderful ideas in the laboratory or in the cadaver lab didn't work in real life. But that's the fun part about academic medicine, as well as the scary part to some extent is getting to ask those questions, getting to study them, and hopefully moving the needle on patient care. Because otherwise, doing Me Too research or writing another paper, another book chapter, okay, at this point, I say yes to those invitations because it helps my residents and fellows and medical students. Mm-hmm. But I need another book chapter like I need a hole in my head, right? So that's not a value to me. It's not a value added, but it's a big value added to my mentees. Mm-hmm. So that's one of the reasons that your CV grows as you become more established is that I have an established reputation. So I get asked to write a book chapter, and it's usually by friends. And so I say yes, and then that gives me an opportunity to let my residents, fellows, and medical students hopefully get something that will help them achieve their goals of, ascending up their ladder.
Absolutely, really, and what an incredible story, really, from developing shoulder robots to or working with Zimmer for new shoulder repairs and to publishing so much. I mean, it's incredible. You've been a residency director, a mentor, and a teacher of the year. You've worn many hats here. What advice would you most often share with medical students and residents pursuing orthopedics?
Well, for medical students, I've so far today met with 3 first-year medical students who just started at Columbia and made appointments to meet with me. And I've given them all the same advice. So I'll share that with you and your listeners. And that is that, at face value, that orthopedic surgery remains one of the most competitive specialties to get to. It's a hard club to get into. But there shouldn't be any mystery as to what you have to do that. Mm-hmm. Whether you still get it or not, if you follow those rules, or pathway or guidelines, that's a different question. But if you don't do the things necessary, then you can't be surprised or shouldn't be surprised if you end up being one of the unfortunate unmatched applicants. So what does that mean? It means as a first year medical student, you have the most time on your hands. Most schools are pass fail for their preclinical years now, so you don't have to really worry about grades. You do need to learn how to be a medical student and to be a successful medical student. And I always remind people that that's your first task, is to be the best medical student you can be. But assuming you have the bandwidth, assuming you can multitask appropriately, assuming you're not diluting your brand, then getting involved with research in orthopedics early in medical school is critical, because many schools like Columbia have an accelerated curriculum now. And so we lost a summer. We don't have a summer between year 2 and year 3. We start the major clinical year, the rotations, if you will, in January of what used to be your second year. And so that means you get one summer between year 1 and 2, and you get those 12 months as a first year student to which you have the opportunity to get involved with orthopedic research. If you don't do that and you're at Columbia, the world knows what our typical VPNS Columbia students look like applying in orthopedics every year. So if you have to answer, why don't you look like the other students? Did you not avail yourself of the resources that we know you have? That can be a challenge. Mm-hmm. So I think it's important to get involved early, shadow early, so that you really know this is what you want to do. Sometimes people think they want to do orthopedics because they had a positive experience in college, or they have a family member, or there's a variety of different reasons. But spend some time with orthopedic surgeons, not just in the operating room, in the office, where we spend a lot of our time. The majority of orthopedic problems don't need surgery. So go spend time in the office, not just in the OR, and really convince yourself that you can see yourself doing this. And finally, the last bit of advice is, whatever specialty you go into, pick the most mundane part of what that specialty has to offer and make sure you're okay with that. Whether that's seeing back pain, or whether that's seeing, your 30th patient in a row who's complaining of 10 minutes of shoulder pain that doesn't need an operation and needs some PT, whatever it happens to be, make sure you're okay with that.
Yes, absolutely. No, I really appreciate that sound word of advice. And with that, I really wanted to thank you for joining us today. I want to be respectful of your time. But this was really an incredible conversation. And I'll be sure. I know a couple people at Columbia interested in orthopedics, so I'll share this with them as well. M1s. So this will be fantastic. I really appreciate it. And yeah. Thank you.
Cameron, thanks so much for having me.
Yes, absolutely. This is Cameron Sabat from Cutting to the Case, signing off. And